I'm Dr. Bhavana Pothuri, and I'm honored to be here to discuss advances in endometrial cancer treatment. Here are my disclosures. So today, what we will cover are the background and molecular classification of endometrial cancer, discuss racial disparities in endometrial cancer, the need for increased diversity in clinical trials, the current standard treatments, recent advances in treatment, and then finally, biomarker-driven treatment and ongoing clinical trials. As a quick review, endometrial cancer has been historically thought of as 4 distinct histologic subtypes: your garden variety endometrioid, carcinosarcoma, serous, or clear cell. And in the past, we have referred to the type 1 endometrioid or hormone receptor positive that are more favorable and have a better prognosis, or type 2s, which are the serous, non-endometrioid, hormone receptor negative that have a poorer prognosis. However, more recently, we have moved from this histologic classification to a molecular classification of endometrial cancer. We've gone from those 2 subgroups, type 1 and type 2, to 4 distinct molecular subtypes. The POLE mutated, which are the ultra-mutated, the MSI high, or the DMMR subset, the copy number low, which usually typically represent the endometrioid grade 1, and finally, your P53 abnormal or copy number high that are more aggressive. When looking at prognostic features of these molecular subtypes, you can see here that the POLE or ultra-mutated have the best prognosis, followed by intermediate prognosis of the green, the MSI high, or the orange, which are the copy number low, and then finally the serous-like or the copy number high, the P53 abnormal, have the worst outcomes. In addition, the prognostic significance of these subgroups have been confirmed in the PORTEC-2 as well. And similar to TCGA, which I just showed you, the PORTEC-2 had similar outcomes in terms of the POLE having the best outcomes and the P53 abnormal having the worst outcomes. In addition, PORTEC-3 confirmed the prognostic significance in high-risk patients, and you can see here both recurrence-free survival and overall survival were similar to what I have just shown you in the TCGA and PORTEC-2. So let's talk a little bit about endometrial cancer epidemiology. It is the 4th most common cancer in women in the United States. It has a 5-year overall survival of 81%. Most are early stage and curable. It is the 6th most common cause of death among women. And I think what's most important to understand is endometrial cancer is the only gynecologic cancer that is rising in incidence and death. And so this is really related to a disproportionate outcome. This results in disproportionate outcomes in minority and racial ethnic groups. So here again, as I said, endometrial cancer, the rate of new cases has increased as well as the number of deaths. And then here you can see the rates of aggressive uterine cancer subtypes that are rising in the United States. And this is more prominent in the non-Hispanic Black population. And then this study is nice because it shows us that the trends in uterine and ovarian cancer mortality rates by race and ethnicity. And you can see here that while ovarian cancer is dropping, the red line, endometrial cancer, is increasing. And this is really related to a disproportionate increase in non-Hispanic Black patients. And over here, you can see that disparity in terms of mortality. This was so much of a problem that the New York Times actually highlighted this, that uterine cancer is on the rise, especially among Black women, really highlighting disparities in outcome and noting that Black women have twice the mortality of dying from endometrial cancer. So I think it's important to touch on this. And, 44% of cancers in Black patients were diagnosed at an advanced or unstaged compared to 29% of white patients. And stage for stage survival was 25% worse. And overall, they had a twofold increased risk of dying from endometrial cancer. So in order to understand some of this, we need to understand the determinants of health. And the determinants of health, you know, can be broken down as follows. Genes in biology only account for 10%. Your physical environment accounts for 10%. The clinical care that we all deliver accounts only for 10%. Health behaviors account for 30%. And the social and economic factors, which we refer to as social determinants of health, account for 40% of, impacting how patients do in cancer with cancer diagnoses. And so understanding disparity in endometrial cancer is multifaceted and complex. The social determinants of health drive health disparities, and NCI defines social determinants of health as the social, economic, and physical conditions into which we are born, grow, live, work, and age in. And these impact every continuum, every stage in the cancer care continuum, from development to risk reduction to early detection, treatment, as well as survivorship. So I want to just discuss the detection of endometrial cancer and looking at endometrial thickness in postmenopausal women. And, Kemi Dahl looked at this and found that the current guidelines missed almost fivefold more cases of endometrial cancer among Black women versus white women. And this is likely related to the higher risk of high-risk histologic subtypes that may have a thin stripe. So really, underscoring that we cannot just rely on this 4 millimeter thickness as a cutoff in terms of assessing for whether there is endometrial pathology, especially in Black women. In addition, Black women are less likely to have guideline concordant care for postmenopausal bleeding. So I think, it's really important that if there is postmenopausal bleeding, that all patients undergo an endometrial biopsy so we do not miss these diagnoses. Let's talk a little bit about some of the molecular differences. This was a paper that Dr. Laura and I published, and it was looking at endometrial cancer in advanced and recurrent cancers and looking at histologic subtypes stratified by race in patients who underwent next-generation sequencing. And you can see here of all patients, when we look at the high-risk histologic subtypes, uterine serous carcinoma, Black patients made up almost 50%. And then when we look at carcinosarcomas, they made up about a third. And then when we look at the genes, we found that there was a difference in terms of Black patients and compared to other patients having a higher preponderance of CCNE1 amplifications. And when we looked at this, we found that, there were 38% in Black patients versus none in white. And then when we looked at survival, you see here that patients who had CCNE1 amplifications did much worse than those that were CCNE1 normal. Again, this is some of the molecular basis that may account for disparities. In addition, Dr. Angela Alvarez-Secord, who spearheads the Endometrial Cancer Consortium, and I looked at real-world data from this and looked again at advanced recurrent endometrial cancer, all histologies. And what we found were that Black patients had a lower proportion of the PTEN and PI3 kinase mutations, which are more consistent with your endometrioid, more favorable endometrial histotypes. And they also had a higher preponderance of those with P53, which have a much poorer prognosis. And in addition, MSI and DMMR were more common in white patients, and those also have a more favorable prognosis. So, and then testing status was unknown for 4.3% of white patients and 1.8% in Black patients. And I think, it's important to understand also when we think about clinical trials and representation that, our clinical trial population is really chosen to represent a larger population. And what we learn from this clinical trial populations needs to be generalizable in terms of the patients that are expected to use the medicine once it's approved. However, Minority accrual in oncology clinical trials is really poor in the United States. Black patients represent 15% of the people with cancer, but only 4 to 6% of trial participants. And Hispanic patients represent 13% of people with cancer, but only 3 to 6% of trial participants. And less than a third of cancer trials are actually even report on race and ethnicity data. So underrepresentation is likely even more extreme. And finally, phase 1 trials particularly do not represent the population with the greatest medical need. And if we don't evaluate these therapies in phase 1, we continue to perpetuate that cycle of disparity and inequity and access to treatments. And this is just a slide showing you race reporting and representation in clinical trials leading to cancer drug approvals. From 2008 to 2018, there were 230 trials and 108 drugs approved, and drug approvals increased during this time. But less than 50% of the trials that led to approvals reported on non-white race. In addition, on the right, you can see here representation that Black patients represented only 2%, and Hispanic patients only represented 1% of patients with known race. When you looked at immunotherapies in gynecologic cancer, we found that the most common agent, pembrolizumab, Black women were disproportionately represented in clinical trials across female malignancies, a 10 to 30-fold lower than expected based on incidence. And so why do we need inclusive participation in clinical trials? To understand the potential differences in efficacy and safety, to reflect the racial and ethnic diversity of the population expected to use the medicine, and to help mitigate racial and ethnic disparities in health outcomes, and to promote justice and equity. And ASCO actually states that access to clinical trials is a critical component of high-quality cancer care. So what are some of the barriers to achieving equity in clinical trials? So there are clinician-related barriers, bias, there are implicit bias is real. We also all have limited time and personnel to search for trials. There are patient-related barriers where patients have limited information. There are financial barriers where they don't have the resources to participate. There is distrust due to historic atrocities like Tuskegee. And finally, there are language barriers. And then in terms of institutional barriers, there are access to trials and not having the right trials open for the patients that you serve, and then diversity of research staff. Patients respond better to people who look like them. So understanding that having a diverse staff is important. And finally, trial barriers, restrictive eligibility criteria. So making the trial overly restrictive when we know that patients of diverse backgrounds have higher comorbidities, including hypertension, kidney functioning, as well as the numerous visits that we ask of patients. And for more complete, resources, you can actually, scan this or go to this website, and you can have a whole host of additional resources. This was just another study that my, former fellow, Dr. Lee, and I looked at, and we looked at endometrial cancer trials that were in clinical trials for clinicaltrials.gov, and we found that, about 10% had language as an exclusion criteria. And then we also found that demographic information, including race and ethnicity, was omitted in more than 40% of published endometrial cancer clinical trials. So the ASCO ACCC has outlined recommendations to increase racial and ethnic diversity in clinical trials and is also a great resource. And this is another paper that on behalf of the GOG and SGO that we published, which also is another great resource. So let's move on to frontline treatment. So GOG 209 established that carboplatin and paclitaxel is the chemotherapy backbone for patients with advanced or recurrent disease. It was a randomized phase 3 trial that looked at the 3-drug combination, doxorubicin cisplatin versus paclitaxel and carboplatin. And then, this trial established that it was a non-inferiority trial, and you can see here there was no difference in outcomes with the 2-drug regimen versus the 3-drug in terms of objective response rate, progression-free survival, or overall survival. So building upon that, Ruby was a phase 3 trial that added dostarlimab to the chemotherapy backbone of paclitaxel and carboplatin. And it was a randomized phase 3 trial versus placebo and carboplatin paclitaxel. And here are the data. You can see here that there was, with the initial presentation, there was an improvement in progression-free survival. And then the updated data that was presented at SGO in 2024 showed a substantial overall survival. This data was published in the New England Journal. And then this, in July of 2023, was approved for DMMR. And now it is approved after the overall survival benefit for both DMMR and PMMR endometrial cancer. This was a study that Dr. Mirza presented, and this was a subgroup analysis in Ruby according to molecular subtype. And it's interesting to note that it appears that all subtypes seem to, the DMMR, the mismatch, the P53 mutant seem to have more benefit than the NSMP subgroup. But I think it's important to remember that these are exploratory only, and we need to evaluate these in a more prospective fashion. Another trial, GY018, was evaluating pembrolizumab with chemotherapy, again in advanced recurrent endometrial cancer with no prior chemotherapy or previous adjuvant chemotherapy if it was completed more than 12 months ago. And they were stratified by DMMR or prior therapy, randomized in a 2-to-1 fashion, pembrolizumab plus carboplatin paclitaxel versus placebo plus carboplatin paclitaxel. And the primary endpoints were progression-free survival in the DMMR and progression-free survival in the PMMR. And these were 2 independent subsets that evaluated this. And here are the results. You saw a substantial PFS benefit, both in the DMMR cohort with a hazard ratio of 0.3, as well as in the PMMR cohort with a hazard ratio of 0.54. And so, and these are additional updates that were presented at SGO. And these were showing that despite high rates of post-immunotherapy, the OS analysis suggested directionally favorable benefit for the addition of pembrolizumab to chemotherapy. So again, and this regimen is also FDA approved, both for mismatch repair proficient and deficient endometrial cancer in the frontline setting. So what about ATTEND? This was the addition of atezolizumab, a PD-L1 checkpoint inhibitor. Again, similar study design, except this was a 2-to-1 randomization. And you can see here, again, there was significant benefit. The PFS was improved in the intent to treat population with a hazard ratio of 0.74. In the DMMR subset, you can see here the hazard ratio was consistent, 0.36. And the co-primary endpoint of OS had a trend for improvement, but the data were not mature. And then you can see here that the PFS benefit of immunotherapy plus checkpoint in the DMMR subset, you can see across trials the consistent benefit that we're seeing in GY018. I mean, look at these curves. They're like so wide. Same with Ruby, hazard ratio of 0.28, and very similar with ATTEND, hazard ratio of 0.36. And then in the PMMR subset, again, you can see here some differences. In GY018, you can see the hazard ratio was 0.54. In Ruby, the hazard ratio was 0.76. And, and this may be related to the addition of having carcinosarcomas, as well as some differences in the inclusion criteria. And then in ATTEND, the hazard ratio was 0.92. In addition, I want to point out that in Ruby, this was the PMMR subset was not a predefined analytic endpoint. So I think it's great that we have all these incredible new medicines, but we looked at real-world treatment patterns and outcomes by mismatch repair microsatellite instability status in patients with advanced endometrial cancer from 2018 to 2023. This was presented at ASCO in 2024. And what we found was among over 1,400 patients, 83% received mismatch repair MSI testing. And then the lack of testing, we did identify that, Black patients and Hispanic patients, as well as those in lower socioeconomic class, were less likely to receive testing. And in terms of HER2 testing, we found that overall about 55% received HER2 testing. And I'm going to talk about that later because we do have therapies that are directed at HER2 and endometrial cancer. And then what we did find, is that over time, we did see an increase in proportion biomarker testing, as well as utilization of immune checkpoint with VEGF therapies in the mismatch repair proficient subgroup, as well as other checkpoint inhibitor regimens among those that were deficient. But despite, all these advances in new therapies, less than 50% of patients are receiving these therapies. So it's really important not only that we discover these new therapies, that we educate and we think about how we can better implement these. So really using implementation science to, speed the adoption of these life-saving therapies is critical. So what about PARP inhibitor plus immune checkpoint in advanced endometrial cancer patients? These are two randomized phase 3 trials that have evaluated this. Ruby Part 2 looked at the addition of niraparib to dostarlimab, and the DuO-E trial looked at the addition of olaparib to durvalumab. So in DuO-E, you can see here, this is the primary analysis was PFS in the ITT population. And you can see that, when you compared arm 1 with arm 3, which was the control, that the durva and olaparib did meet its primary endpoint with a hazard ratio of 0.55. However, I already showed you that, we have really made incredible progress in the DMMR subset where we have a hazard ratio of 0.3. So the subset that we really need to make improvements in outcomes are in the mismatch repair proficient subgroup. And here, when you look at this subgroup, you can see here, again, when you compared with control, the hazard ratio was 0.57. And I think, the elephant in the room is we don't know what the benefit of just single agent olaparib is. We see that it's control versus durva and olaparib. And then, when we see durva versus durva and olaparib, we see a benefit, but this was not a pre-specified endpoint. So we'll have to see, what happens in terms of FDA approval and how we can incorporate this therapy into our practice. In terms of the Ruby trial, this was Ruby Part 3, which looked at the addition of niraparib to dostarlimab versus placebo and placebo here, and you can see that there was a benefit showing it met its endpoint. It showed significantly and clinically meaningful improvement in the PFS for the dostarlimab and chemotherapy, followed by dostarlimab and niraparib in this was the overall population as well as the mismatch repair proficient population. And I think, again, the elephant in the room is we cannot tweak out the contribution of components. Is the PARP inhibitor driving this? So I think more to come, but, until that's sorted out, I think it'll be really hard to understand the role of PARP in endometrial cancer. What about frontline immunotherapy versus chemotherapy? So the question is, can we replace immunotherapy for chemotherapy? So in the Keynote C93 and Dominica trials, these are both DMMR patient populations of endometrial cancer in the frontline. They are evaluating this exact question. In both of these trials, The data is maturing, and hopefully we'll have an answer soon. In addition, LEAP-001 looked at the combination of lenvatinib and pembrolizumab versus chemotherapy. And this trial, unfortunately, did not meet its endpoint, and this looked at both DMMR and pMMR populations. So the question becomes, how can we improve outcomes further in frontline mismatch repair endometrial cancer? We talked a little bit about the addition of a PARP inhibitor, but we are now looking at, can we add antibody drug conjugates in the maintenance phase to our immunotherapy backbone? And there are two ongoing trials, MK2870, Trophus 033, which is GOG 3119, and Destiny 01, which is GOG 3098. The first trial here, Trophus 033, is looking at the addition of sac-TMT, which is an two-directed antibody drug conjugate, to pembrolizumab in the maintenance setting. And then in the Destiny trial, they are actually randomizing patients to a 3-arm trial looking at TDXD, which is the HER2-directed ADC, plus Rilvi, which is their PD-1 plus TIGIT bispecific, versus TDXD and pembrolizumab versus carboplatin, paclitaxel, and pembrolizumab. And so this will be not just in the maintenance, but at the start of therapy and into the maintenance. And so I think these two trials will help us define how we can improve outcomes further in mismatch repair proficient endometrial cancer. Another trial looking at mismatch repair proficient endometrial cancer. This is a trial that is adding bevacizumab to the carboplatin, paclitaxel, pembrolizumab backbone. And this trial is actually going through the NRG, and it's been approved by the GCSE. So hopefully we will also have this trial to help us in this subset. Let's move on to recurrent disease. I think it's important to get back to this idea of the 4 molecular subgroups, and we'll start out talking about the DMMR subset. We have Keynote 158, which looked at patients with MSI-high DMMR advanced endometrial cancer. And you can see here the objective response rate in recurrent endometrial cancer, 48%. You can see here the waterfall plot. This was FDA approved in 2017, and this was the first biomarker agnostic approval. And this received regular approval in March of 2022 for endometrial cancer that was MSI-high DMMR that progressed on prior systemic therapy. Another PD-1 agent, dostarlimab, and I worked on this trial, and this also had a significant objective response rate of 45%. It was a large subset of DMMR and pMMR endometrial cancers, and you can see the waterfall plot here and beautiful activity. And so this received FDA approval in 2021 and regular approval in 2023. And so that's great, but can we use immunotherapy? We can use immunotherapy in DMMR, and here are the objective response rates in larger subsets. However, what about in the mismatch repair proficient subgroup? Again, you can see that those rates are much lower, ranging from the 3 to 14%. So in order to build upon that, Keynote 775 added lenvatinib to pembrolizumab, and this was a randomized phase 3 trial that looked at pembrolizumab and lenvatinib versus your standard chemotherapy in the recurrent setting, doxorubicin or paclitaxel. And the primary endpoints were progression-free survival and overall survival. And here you can see in the mismatch repair proficient patients a meaningful benefit in the mismatch in terms of progression-free survival, 3.8 versus 6.6 months with a hazard ratio of 0.6. And then you can see here the overall survival benefit in the mismatch repair proficient subgroup here, 12 to 17.4 months, and this is in the all-comers. And again, a hazard ratio you're seeing of 0.62, and in the mismatch repair proficient, a hazard ratio of 0.68. This led to accelerated approval in September of 2019, and then full approval in 2021 in advanced mismatch repair proficient endometrial cancer that progressed following prior systemic therapy. So I think it's important also to think about now, it's great that we have these regimens that are approved, but what really is the value in a post-IO setting? I've just talked to you about, immunotherapy has been now approved in the frontline setting, so all our patients are going to be getting it regardless of mismatch repair status. So so the relevance of these studies comes to question, and we don't know what the real efficacy is after, IO in the front line. And then I think it's important just to touch on safety. I think with lenvatinib, we do need to understand that there was a high discontinuation rate of almost 33%. The most common treatment emergent at grade 3 events were hypertension, weight in almost 40% of patients, weight decrease in 10%, diarrhea, proteinuria, fatigue. And so it is really important to be aggressive about managing the hypertension and being on top of, dose reductions and dose holds as needed. So let's talk about endometrial cancer that is copy number low, or NSMP. So again, these are your garden variety endometrioid patients. And, we do know that hormonal therapy has some efficacy. And megestrol acetate was actually approved by the FDA in 1971. However, we see response rates varying from 14 to 33%. And we see progression-free survivals of only 2.5 to 3.2 months. So the question was, can we build upon this? And this study was looking at everolimus letrozole compared to Megace and tamoxifen. And you can see here that the objective response rates were very similar. However, the progression-free survivals were improved in this study. And so it brings us to, think about how can we expand on that everolimus and letrozole data. So CDK4/6 inhibitors, we know that hormonally driven malignancies are known to have an actionable therapeutic target with CD4K6, and they induce cell cycle arrest at the G1S checkpoint. And the cyclin D CDK complex is downstream of the estrogen signaling, and it represents a potential synergistic anti-tumor activity when combined with an aromatase inhibitor. So the Paleo trial was a randomized phase 2 trial that was done, and patients were randomized to placebo and letrozole versus palbo and letrozole. And the primary endpoint was progression-free survival. And these were patients who, had recurrent endometrial cancer and no prior endocrine therapy except for medroxyprogesterone or megestrol acetate, and no prior CDK6 inhibitor. And here are your data, and it did meet its endpoint. The hazard ratio was 0.56. The median overall survival was 3 versus 8.3 months. And you can see the the disease control rate was improved as well. However, it is a small number of patients. You can see here 36 in the palbo-letrozole and 37 in the placebo-letrozole arm. Another phase 2 study that was done that looked at letrozole and abemaciclib in estrogen receptor positive or recurrent metastatic endometrial cancer patients. Again, a single-arm 30-patient trial, but did show efficacy 30% in patients. And so, this is actually a proposed trial for the NRG. We have a phase 3 trial that one of my former fellows, Dr. Junia Feniger, and I are putting together, evaluating ribociclib and letrozole versus investigators' choice therapy, and that could be endocrine therapy or chemotherapy in recurrent NSMP ER positive endometrial cancer with a primary endpoint of investigator-assessed PFS. I think it's important we talk about selinexor, which is an XPO1 inhibitor. Exportin is a major nuclear transport protein for tumor suppressor proteins. And inhibition of XPO1 impacts tumor by reactivating multiple tumor suppressor proteins, and it prevents nuclear export and inhibits oncoprotein translation. And it is an oral selective, selinexor is an oral selective XPO1 inhibitor. This was the SIENDO trial, and this was in high-risk endometrial cancer patients, stage 4 or first relapse in endometrioid serous or undifferentiated or carcinosarcomas. Patients were randomized 2-to-1 to receive selinexor, 80 milligrams weekly versus placebo until progression, and the primary endpoint was progression-free survival. And you can see here the PFS in the ITT population. In the audited data set, there was modest benefit in the entire population, the ITT population. However, when you looked at a pre-specified exploratory subgroup in patients with P53 wild type, you can see here that the significant difference with a hazard ratio of 0.375. And then continued long-term follow-up showed that this was maintained in the P53 wild type patients with a hazard ratio of 0.42. So that has led us to a prospective trial evaluating patients with P53 wild-type endometrial cancer. Patients are randomized 1-to-1, selinexor 60 milligrams versus placebo, with the primary endpoint as progression-free survival as assessed by the investigator. And then at this point, I think it's important we move on to talk a little bit about the copy number high, as these are the patients that have the worst prognosis. So we know they comprise about 25% of the endometrioid and the majority of other high-risk histologic subtypes. We know that TP53 is noted in over 90% of these patients. We do see ERBB2 and we see BRCA as well as HRD in this subgroup. This is just to show you that, we see both HER2 as a player in uterine carcinosarc as well as uterine cancer. This was the first trial that Dr. Fader presented back in 2018, published back in 2018. And this was a randomized phase 2 of 41 advanced cancers and 17 recurrent serous cancers that were IHC 3+ or 2+ FISH positive. And you can see here a significant benefit in the ITT population in terms of PFS. And when you look just at the advanced stage disease, you can see an even greater benefit with a hazard ratio of 0.4. And then when you look at overall survival, you can see that there was a difference, especially when you look at advanced stage disease. This was significant with a hazard ratio of 0.492. And this is in the ITT population here. So that has led to GY026, which is led by Dr. Britt Erickson. And this is a randomized phase 3 trial that is ongoing, looking at paclitaxel carboplatin versus paclitaxel carboplatin trastuzumab and pertuzumab versus carboplatin paclitaxel and trastuzumab. And this is all stages and this is currently in its phase 3 and accruing very well. What about other, opportunities? WEE1 inhibition is an opportunity for synthetic lethality. We know that, TP53 mutations are noted in about 90+%, and we have CCNE amplification in about 25%. And the loss of the G1S checkpoint increases replication stress and increases the dependency on the G2M checkpoint. And WEE1 regulates the G2M and checkpoint. So adavosertib was evaluated in a single-arm trial, and the objective response rate was noted to be 30%. You can see the waterfall plot. However, it did have significant toxicity that has led to halting further advancement. There are other WEE1 inhibitors as well, the ZNC3, that also had significant response rates. And again, I think we'll have to see how we can mitigate toxicity to move those forward. In terms of other other therapies, I think we can't ignore, we are in an era of antibody drug conjugates in gynecologic cancer. The treatment of GYN cancers is becoming more targeted. We have PARP inhibitors for BRCA and HRD in ovarian cancer. We have immune checkpoint inhibitors in endometrial cancer. And I think the next step towards these individualized or personal therapies are targeting tumor-specific antigens to enhance drug delivery directly into tumors. And I think these will eventually replace our standard chemotherapy options. We see here that there are 3 components. We have a highly selective monoclonal antibody for tumor-associated antigen that has restricted expression on normal cells. We have a linker here that is really important, especially in terms of adverse events. And then we also have the cytotoxic drug, which can be selectively deployed into the tumor cell. So let's talk about the Destiny Pan-Tumor02 study. This looked at TDXD in HER2-expressing solid tumors. It looked at advanced solid tumors that were not eligible for curative therapy, second-line plus patient population. They needed to have a HER2 IHC 3+ or 2+, and prior HER2 targeting therapy was allowed. You can see here were the different cohorts. There were 3 GYN cohorts, and I'm going to focus on the endometrial cohort today. And you can see here the efficacy by HER2 status among all comers. It was 58%. Again, I think it's important to keep in mind this was a subset of 40 patients. However, when we look at the 13 patients that had IHC 3+, 11 responded, 85% response rate. And then when you look at the progression-free survival, again, there appears to be differences in terms of the 3+ when you compare it to the 2+. And again, these are small numbers and the confidence intervals cross, so we're going to have to wait and see. But this certainly is intriguing. And the same is true of overall survival, where there appears to be a difference in terms of 2+ and 3+. And this has been FDA approved, again, a tumor agnostic approval in HER2 solid tumors in April of 2024. What about, other histologies? I like this trial because it shows that there is efficacy in terms of uterine carcinosarcoma. The objective response rate in a small cohort in the HER2 high of 22 patients was 55%. In addition, you can see here SYD985, another HER2 ADC, did have an objective response rate of 39% in endometrial cancer. So currently we have this trial that Dr. Forblakis is the PI on. It is GOG 3105. It's a randomized phase 3 trial of HER2 ADC BNT323 versus investigator's choice chemotherapy in previously treated patients with HER2 expressing recurrent or metastatic endometrial cancer. But in addition, can we also target endometrial cancer with the TROP2 ADC? And so we have data from 3 different TROP2 ADCs, sacituzumab govitecan, sacituzumab termotecan, and datopotamab deruxtecan. And you can see across the board there is objective response rates. And here we see there are 2 current randomized phase 3 trials of TROP2 ADCs in recurrent endometrial cancer that are currently ongoing. And this is the GOG 3095, which I am honored to be the global PI on, and this compares the MK2870 versus doxorubicin paclitaxel, and then GOG 3104, which my good friend Dr. Ramez Eskander is the the global PI on, and this is randomizing sacituzumab govitecan to doxorubicin or paclitaxel. So I think it will be important to await study completion and results to see if these will have a role in the treatment of recurrent endometrial cancer as well. And it also tell us whether biomarker is important in these trials. I think I'm going to use this as just to show that, we can also use FR alpha targeting ADCs, and this was using luveltamab tazevibulin. There are other ADCs also targeting the folate alpha receptor in endometrial cancer. So just as a summary, these are some of the other HER2 ADCs. In addition to TDXD, we have DB1303. We have the folate receptor alpha with mirvetuximab, IMGN151, the PRO 1184. We have TROP2s that I discussed. And then our latest target is the B7H4 with Puxi-Sam. So stay tuned, more to come. But I think I would be remiss if I did not talk about antibody drug conjugate mechanisms of resistance. As you can see here, there are multiple different mechanisms of resistance that may emerge, and we need to start understanding this so we can better design trials for sequencing in the future. For example, this is what they've done in breast cancer, and what they found that SASI-G followed by TDXD actually resulted in improved outcomes versus TDXD followed by SASI-G. So obviously this is also a very small number of patients, but we need to start doing sequencing trials, especially in patients with assets that have been FDA approved. So in summary, endometrial cancer is a molecularly driven disease with 4 distinct subtypes. There are substantial racial disparities that exist in endometrial cancer, and we need to increase our efforts to mitigate these racial disparities. Phase 3 trials of immunotherapy in combination with chemotherapy are positive, and so the addition of immunotherapy in the front line is standard of care in endometrial cancer, both in dMMR and pMMR. The role of PARP inhibitors, I think we have to wait and see. Dostarlimab and pembrolizumab have shown promising efficacy in dMMR MSI-high endometrial cancer as monotherapy, and both are FDA-approved therapies for recurrent endometrial cancer. And, I think I have to leave you with the caveat that, the efficacy of these therapies are unknown after IO in the front line. And same goes true with pembrolizumab and lenvatinib, which has showed promising efficacy in mismatch repair proficient recurrent endometrial cancer. And again, we don't know what the efficacy is after frontline use of immunotherapy. Finally, the role of hormonal therapy with CDK4/6 inhibitor therapy in copy number low microsatellite stable endometrial cancer needs further evaluation in a phase 3 trial, and hopefully we will have that soon. Selinexor in P53 wild type endometrial cancer needs evaluation in a phase 3 trial, and that export EC is ongoing. The role of trastuzumab and other HER2-directed therapies for biomarker-positive tumors needs further investigation, and we have GYO26 as well as other trials investigating HER2 ADCs. The WEE1 inhibitors, though promising, have toxicity challenges, so we'll have to wait and see how those will pan out. Finally, antibody-drug conjugates will likely replace chemotherapy. TDXD is already approved in patients with 3+ IHC recurrent endometrial cancer. And I want to leave you all with, it's an exciting time for endometrial cancer patients because the treatment paradigm has changed significantly in the recent years, and it's going to change more, and we're going to have more therapies. This is my incredible Gynecology team at NYU Manhattan, Brooklyn, and Long Island. And this is my incredible CTO leadership team that allows me to do the work we all do together. Thank you.